He mihi kia koto. I acknowledge the na atua and the tangata whenua of this rohi. He mihi whakamana kia tatau. Maori ora, may the essence of who you all are thrive. Kia ora, everyone, and good morning. Thank you so much to the Cutting Edge conference organizers, especially to Sue Pettin, for the opportunity to be here in beautiful Aotearoa to share my work. Ane te whakapapa. My name is Seema Clifasefi, and I am an associate professor at the University of Washington-Harborview Medical Center, where I live in Seattle, Washington. I also co-direct the Harm Reduction Research and Treatment Center with my colleague, Dr. Susan Collins. And at the Heart Center, we work collaboratively with substance users and their communities to co-develop, evaluate, and disseminate evidence-based harm reduction interventions that really are in service of reducing substance-related harm and improving quality of life for the affected individual and their larger communities. Our beautiful Mount Rainier sits in the backdrop of our fair city, and my eldest son carries this namesake. I'm the daughter of Iranian immigrants, born in America, married to a Kiwi, so I carry multiple identities. I initially trained as a cognitive experimental psychologist under the guidance of Dr. Marianne Gary here at Victoria University in Wellington, where I received my PhD in 2003. I want to acknowledge another important academic ancestor of mine, Dr. Alan Marlatt. Alan was my mentor between 2003 and 2011 at the Addictive Behaviors Research Center, where I secured a postdoctoral fellowship and then went on to become a faculty member after receiving my PhD from Victoria. Alan was a giant in the field of addiction and one of the first US proponents of harm reduction. He was a pioneer in this area who really brought compassion and empathy to the field of an addiction, a field that needed that so desperately. He's the one that taught me about harm reduction, and the Harm Reduction Research and Treatment Center that my colleague Susan and I set up is really our tribute to Alan and our contribution to the field of addiction. So I want to start off by saying that substance use is here to stay. And the sooner we can accept this fact, the sooner we can work toward pragmatic and compassionate solutions to addressing the harms associated with substance use and to work towards improving the quality of life of affected individuals and communities. So just to give you a little bit of a roadmap of where we're going in the next 50 minutes or so, I'm going to give you some background information and some statistics that I hope will challenge you and give you reason for why you should care about what comes in the rest of my talk. And then I'll share some of the science that I've been involved with supporting harm reduction approaches, from housing people experiencing homelessness to development of alcohol and other substance-specific harm reduction interventions, to, as we heard from our distinguished speaker before, diverting low-level drug offenders and sex workers out of the criminal justice system and into harm reduction services. And then finally, I'll conclude with some thoughts, maybe some lessons learned that New Zealanders can kind of take away and think about, especially as you have some upcoming elections, I hear. So drugs and drug use has been around since the dawn of time. As you can see from this timeline, the first evidence of substance dates back to 9,000 BC with hallucinogens, followed by alcohol roughly 2,000 years later, and so forth and so on. So scientists have found illicit substances in human remains and fossils. So drugs are in our DNA. And I don't know about you, but if history is anything to go by, I would say that drugs and our propensity to use them is not going away anytime soon. So if we're going to make any strides towards substance use and misuse, I believe we need to accept this fact first and foremost. However, while substances and substance use has been around since the dawn of time, our approach to how we deal with people who use substances and our laws and our drug policies have shifted and changed over time. And I would argue that many of these policies have been racially charged. For example, the anti-opium laws of the late 1800s targeted Chinese immigrants. The anti-cocaine and later crack laws right throughout the 1900s affected primarily Black and African American communities. And the first anti-marijuana laws in the early part of the 20th century were directed at people of Hispanic origin. So let me just give you an example. When laudanum, which is a cinnamon-flavored alcohol-based tincture with high levels of opium, when that was being used by white, upper middle class Victorian era housewives for headaches and depression, no problem. When Chinese laborers came over to the United States to come and work on our railroads and started smoking opium after a long days of work, the smoking of opium actually became criminalized, not the ingesting, which was the white people's way. Similarly, we see a same story with our cocaine laws. So when poor inner city African American communities started smoking distilled cocaine mixed with baking soda and water, a cheaper, much more accessible form, also known as crack, we literally cracked down on crime. As an example of the disparities in sentencing, between 1986 and 2010, when Obama signed a drug parity law, in the US, federal penalties for crack, typically found on Black people, were 100 times harsher than those for powder cocaine, typically found on white people, despite no chemical differences between these two substances. So this war on drugs has been a failed policy that has had a devastating effect on our most marginalized and vulnerable communities. Not only that, it has meant a $1 trillion price tag over the span of 40 years. I don't even know how many zeros that is, but it's a lot. It's meant a 500% increase in our incarcerated population over the past 40 years, making the United States one of the largest incarceration rates in the world with 2.2 million adults. Our imprisonment rate is about 666, which is quite an auspicious number, per every 100,000. And according to the Federal Bureau of Prisons, of those 2.2 million adults in jail or prison, almost half of them are incarcerated for low-level drug offenses. Moreover, there is a disproportionate rate of minorities in jail and prison in the United States. Our most recent statistics tell us that Black people are incarcerated at 6 times and people of Hispanic origin at 3 times the rate of their non-Hispanic white counterparts. So to put that another way, 1 in every 15 African American men and 1 in every 36 Hispanic men are incarcerated in comparison to 1 in every 106 white men. In case you think these statistics just apply to America, let's talk about New Zealand for a minute. New Zealand has the 2nd highest incarceration rate in the Western world. Your prison population is at an all-time high with an imprisonment rate of about 212 per 100,000 population, which is 34% higher than Australia and 73% higher than Canada. And this is not the thing you want to be beating Australia in. Granted, about 10% of your prisoners are in for drug-related offenses. However, if you end up adopting some of the tough-on-crime policies that I've been reading about in these past weeks, including an $82 million initiative to target gangs and eradicate meth use, you're going to see that 10% rate increase dramatically. And again, I do not think you want to follow the United States on this statistic. We heard from our speakers yesterday that although Maori constitute only 15% of the general population, they account for roughly 51% of the prison population, making them 6 times more likely to be incarcerated than non-Maori. Sounds pretty familiar. Let's talk about the cost of substance use. According to recent reports, the United States estimated the cost of substance use to translate into roughly $740 billion annually. And these are costs related to our criminal justice system and lost work productivity and healthcare costs, including both psychological and physical health. In New Zealand, the 2016 harm index estimated this cost to be roughly $1.8 billion. So I've heard a saying, in doing research for this talk, I've been speaking to a lot of people on the ground working in the system, many of you, and I've heard a saying here in New Zealand that if it's good for Maori, it's probably good for Pakeha. And many of you may have heard of the hashtag Black Lives Matter movement happening in America right now. The idea being that when Black lives matter, all lives will matter. And I believe these two things to be true. The reverse, however, is what I would refer to as institutionalized racism. Why? Because the dominant culture gets to make the rules and dictate them. And the non-dominant minority populations have to figure out how to conform to these rules in order to survive. And what we so often see is that the survival rate is not that great. Now, I know that the United States and New Zealand have very different histories, and we're very different countries. But what I do know is that Black and brown people in both countries are dying at much higher rates, criminalized at much higher rates, and disproportionately represented in all of the various sectors where you do not want to see these kind of disparities. A recent article in New Zealand News Hub last week pointed out that Maori communities continue to have the highest suicide rate in the world of any ethnicity. And this is not acceptable. And in fact, in New Zealand, I believe that this is not honoring your Treaty of Waitangi. But I've been invited here to talk about how addiction is everybody's business. So you may be wondering, why am I spending all this time talking about race and poverty and incarceration and the war on drugs and health disparities? What does this have to do with addiction? I believe that we cannot talk about addiction in isolation of these things, and that race and poverty and crime and substance use are all inextricably linked. And this is precisely why I think addiction is and should be everybody's business. When we treat addiction in isolation as an individual problem, we are ignoring all of the socio-economic, political factors that contributed to these issues and that we as a society created. When we treat people with substance use problems as criminals, we are not only dehumanizing them, but we're also not figuring out ways to provide them with the help that they need to become positive, contributing members of society. We are feeding into this narrative of moral failing, of blame and shame and stigmatizing people. And if we truly want to address the issue of addiction, we need to make addiction everybody's business by educating people about addiction, how it develops, the pragmatic reasons that people use substances, the harms and the relative risks associated with different substance use, our drug policies, and really help place substance use in the larger context so that we can help build people's empathy and compassion around those suffering from substance use problems, and better help people understand that our current hardline approaches are not working. When we make addiction everybody's business, particularly the business of the person themselves who is experiencing it, we are better equipped to be informed, to have multiple perspectives, to have wisdom that will help us address issues in culturally relevant and more feasible and acceptable ways. So I mentioned at the start of my talk that substance use is here to stay, and I really believe that. And I'm not saying that to cause people to feel hopeless or gloomy or to give up on ways to find solutions. But I'm also a pragmatist. Drugs in and of themselves are not inherently bad. In fact, there are many very positive and practical reasons why people might use substances. It's our relationship to these substances that we need to be looking at. Why are we so drawn to these substances? What is it we're looking for? And how can we heal our pain in alternative, less harmful ways? These questions are ones that I think about as a substance use researcher, and the ones that have ultimately led me to adopting a harm reduction approach to substance use. So we heard from Dr. Evans yesterday that our treatment system isn't working. So not only is the war on drugs, has it been a dismal failure, but our current treatment system is also not meeting most Americans' needs. So according to the Substance Abuse Mental Health Service Administration, in 2013 in the United States, there were 22.7 million Americans who needed treatment and only 2.5 million Americans who received treatment. So that's about a 10% hit rate. Whereas in New Zealand, we heard from Dr. Evans yesterday that that hit rate's a little better, about 30%. But traditional treatment is not reaching the people who need it. And why is that? Most people in this survey felt that they didn't actually need treatment. The stigma and shame that we have attached to substance use disorders have only served to get us more distant from the path to healing. Words like addict, criminal, junkie, druggie, meth head, they're all used in a derogatory way and serve to shame and blame the person who uses substances. If we want to get people the help that they need and create happier and healthier communities, we need to change the way we think about substances, and we need to change the way we talk about addiction. But that is a whole nother talk. So I know it's an election year here in New Zealand, and the approaches to how we treat people with substances is a hot item on the political ticket. And I'm hoping that people will come to understand through this talk that the war on drugs and the tough on crime approach have not worked out well for us as a society. And they've simply been a war on race and poverty. I also understand in talking to many of you that there have been a slate of overdose deaths related to synthetics. And I also understand that there was a point in time where these synthetics were actually being regulated, and that that's no longer the case. And the problem I see with these type of restrictive policies is that they, one, drive the drug use and the behavior underground, and they also lead to preventable deaths. Similarly, our tough love approach to substance use and treatment has definitely not borne out. We heard from the honorable judge about when the family disconnects the person, those are the people that are less likely to make it through drug court. This is our tough love approach. It's the one where we gather all the people who love the individual and say, we're cutting you off if you can't stop using. This approach only serves to make people feel less connected, more isolated, more deep in their shame. So what this tells me is that we need a new way forward, and harm reduction offers an effective alternative for those who are not ready, able, or willing to stop using. So harm reduction at its core is a pragmatic and compassionate approach to minimizing the harms or negative consequences associated with substance use and maximizes well-being and quality of life. So Johann Hari, who's a journalist and author of Chasing the Scream, and incidentally, I hear a rumor that he may be headlining next year's conference, so I won't try and steal his thunder too much. But in a TED Talk that he's given that has received over 7 million views, he purported that the opposite of addiction is not sobriety. The opposite of addiction, he said, is connection. And I wholly subscribe to this philosophy, and I'm here today because my own research and work has shown this to be the case. So in the next part of this talk, I want to share with you the science on harm reduction that I've had the honor of being a part of over the past decade in Seattle. And this work that I've been associated with has meant major policy shifts in how Americans conceptualize housing for people experiencing homelessness and substance use problems. This work has meant major policy shifts in drug laws and criminal justice reform. And more than that, this work has meant that people who use drugs have been humanized, are treated compassionately, and given autonomy and self-determination to make decisions about their own journey of healing. So in Seattle, I work primarily with people who are experiencing homelessness and substance use problems and/or have come into contact with the criminal justice system because of these issues. So in 2016, an estimated 549,928 individuals were left homeless on any given night nationwide. In 2016, this number was estimated at about 4,505 people in Seattle, making it one of the largest homeless populations in the US. So those experiencing chronic homelessness are disproportionately affected by substance use, mental and physical health, and their average age of death is between 47 and 52 years old. That is worse than the life expectancy in third world countries. And for the richest country in the world, this is not acceptable. Homelessness continues to grow, displacing more people, youth, and families, and I know that this is a rising issue in New Zealand. According to the latest numbers that I could find, the total number of homeless people experiencing homelessness in New Zealand was roughly 41,075, or 1% of your total population. And between 2006 and 2013, New Zealand's population grew by 4.8%, while the number of homeless grew by 25%. Homelessness is an issue, and we need to do something about it. And one response to this issue has been a housing first approach. And we heard a little bit about housing first in Dr. Evans' talk yesterday, for those of you who were here. So I just want to let you know that Housing First, so in 2005, Seattle's Downtown Emergency Service Center opened a Housing First program known as 1811 Eastlake. 1811 Eastlake is the flagship single-site Housing First model in the country, in the United States. It was the first of its kind. Housing First is also dubbed harm reduction housing. It's predicated on a belief that housing is a basic human right and not a reward for good behavior. It's permanent, supportive housing offered to individuals with histories of chronic homelessness and alcohol use problems in Seattle without preconditions such as alcohol abstinence or treatment attendance. This particular house houses 75 individuals who were deemed by our county, I don't know what that is in the background there, deemed by the county as some of the highest utilizers of publicly funded services in our city. So these were people who were using emergency services, going to the ER for their medical care, cycling in and out of jail, using publicly funded detox systems. And the University of Washington's Addictive Behaviors Research Center, where I was working at the time, was invited to evaluate the program. So I just want to point out some news articles that came out before this model actually got underway. So talk about dehumanizing. Look at these newspaper ads. I'm sharing with you because I know that New Zealand is considering implementing Housing First, and already I also understand that there are some programs underway here in New Zealand. So I just want you all to be prepared for the discourse and some of the moralistic judgment that comes with this kind of policy. So you see housing for street alcoholics opposed, Seattle to build housing for street drunks. My favorite, liberal lunacy mandates drunk dorms as a homeless cure. We have Ken Schramm, who was a very notorious reporter in our area, saying, "Too bad stupidity is legal." So we were invited to do this evaluation. This was the political backdrop. And the question was, is this a bad idea? Is this going to make people worse, giving people pretty much no strings attached housing? Is that going to make their alcohol use worse? Is that going to cost the system more money? These were all the questions that we were tasked at finding out. So I'll keep this to a minimum, but just those of you who are researchers in the room, the aims of the evaluation were really to evaluate the association of a Housing First intervention, to look at healthcare costs and utilization and alcohol use outcomes primarily. We used a quasi-experimental design where we compared outcomes for individuals who were housed in this building versus those who were on a wait list to get into the building. And we looked at the use and costs of publicly funded services, criminal justice, hospital, emergency room, medical services, public drug and alcohol detox. And the reason that we looked at economic costs first is because there was so much political backlash that we wanted to know if this approach actually worked and helped to save money. That was one strategy that could help possibly make people listen and soften their tone. So these are the demographics of the population. And I just wanted to point out, again, the disparities. Despite making up less than 1% of the greater Seattle population, American Indian Alaska Native, so our indigenous people, made up over 1/3 of our sample. I just want to give you a little bit of a sense of what residents' alcohol use looks like in this constellation. So 90% of our participants met criteria for alcohol dependence. 96.5% of them met criteria for alcohol abuse. Their standard drinks per day were 24.4. And their peak alcohol, so the highest drinks in the past 30 days was 40 drinks. These are levels that would potentially kill many people. But these are people who have developed so much tolerance and have been drinking for 20, 30 years of their lives. We also see that they've had 16 lifetime episodes of traditional treatment. And those treatments, if you go to lifetime treatment for 16 times, clearly something is not working for you. I also just want to point out what's more striking about this population, and sadly one that we don't talk about as much, but it's the resilience of these people. I have been so humbled to work with these individuals who are some of the wisest people I have ever had the opportunity to know, and I have worked with really smart people. They are funny, they have a sense of community, and I just cannot tell you enough how amazing these individuals are. But most people look past those things. They don't even bother to look at these people or just, turn away when they see these people on the streets. And what I want you to take away is that everybody has a story. Everybody is placed in context, and if you just take time to actually get to know that person's story, you can start developing your own compassion for these individuals. So, how did Housing First fare? Well, Housing First in the first year of operation was associated with over $4 million in taxpayer savings, with just 75 people, mind you. We also saw significant decreases in alcohol use and related problems, despite not providing any conditions that the people stop using alcohol or change their drinking in any way. We saw significant reductions in jail days and jail bookings, significant reductions in emergency medical service use. But more than any of that, Housing First was seen and is cited by the residents as the thing that saved their lives. So basically, over a decade of research conducted by my colleagues and I tell us what we already intuitively knew, that housing does and should indeed come first. And I also just want to dispel something that Dr. Arthur Evans said yesterday. He was mentioning that Housing First doesn't work so well with people who use substances. And I'd like to actually challenge that and say, in fact, all the research that I've been doing over the last 10 years suggests that, yes, it does in fact work for people who use substances, and that is primarily why it was set up in the first place. So if we know that housing first, or housing comes first, the critical question is, well, what comes next? So I want to point out to you that although we know that Housing First helps people reduce their substance-related harm, there is still harmful drinking occurring at 1811. So this what comes next question really was born out of a conversation with the late and beloved Bill Hobson, who was then the executive director of the Downtown Emergency Center, and he is now passed on. But once we had established all this evidence and we had convinced the policymakers and convinced the public that stupidity was a really brilliant idea, Bill sat down with Susan and I and said, all right, ladies, you're the experts in substance use. You tell us, how can we continue to reduce the harm that people experience? And Susan and I looked at each other and thought, okay, so neither of us have the lived experience of homelessness. I certainly have not had the lived experience of having a substance use problem. So we did the only thing we knew how to do, and we turned to whom we thought were the true experts, the community. And this was a theme pervasive throughout all of the talks yesterday. So we turned to the people with lived experience of homelessness and alcohol use problems and asked them what they wanted to see happen in their community. And again, what we heard from residents and what we heard from staff working in these spaces is that they felt that harm reduction approaches were the only thing that would work. And I also want to have you recall that about a third of our population identified as having Native heritage. And so we also heard very loud and clear that there was a desire for more diversity in staff. At the time that we did this evaluation, 100% were European American, 100% of the staff were European American and only English speakers. So the residents wanted more opportunities to reconnect with their cultural practices and more culturally appropriate programming offered to them in the community versus traditional treatment. And from this, the Life Enhancing Alcohol Management, or the LEAP, was born. So the LEAP is a 5-year study funded by the National Institutes of Health, awarded to me 5 years ago now, so we're coming up to the end of the grant. But it's been a collaboration between academics, housing and healthcare providers, and affected community members, where we literally bring everybody to the table and talk about ways that we can reduce alcohol-related harm and improve quality of life in that community. We use what we call a community-based participatory research framework to co-develop and evaluate these programs. And when I say community-based participatory research, again, I've heard this throughout the various talks here. I guess they... Oh, is that the wind? Oh my goodness, Wellington wind. Okay, well, I guess we can't do anything about that. So, it's just the wind is speaking back. It's like Dr. Evans said, you know, when you put something out there, you want to hear back. I guess that's what's happening now. So, what do I mean when I say community-based participatory research? Really, this is a much more collaborative and equitable approach to research. It takes topics that are of importance to the community. It capitalizes on partners' unique strengths and lived experience and all of the wisdom that goes along with that. And it also is the social justice way of doing research. So it combines this knowledge and action to achieve social change. And so really the intent is to transform research from a relationship where we're acting upon a community to one in which individuals are working side by side. And again, throughout the talks yesterday, I heard this loud and clear. So we're all calling it, you know, participation and getting people involved. But the idea with community-based participatory research is that the collaboration itself is one path to healing. So just to give you a very brief overview, we used a three-phase process where first we went and talked to the community to find out what they wanted to see happen. We conducted very stringent qualitative analyses of all of the interviews, as well as naturalistic observations where you know, we spent time in the housing program. We then engaged the community and formed a community advisory board made up of voted upon resident leaders in the community as well as staff and management to develop and implement resident-driven programming. And then in the final phase, we used a non-randomized control trial to evaluate this pilot program as compared to Housing First as usual. So I just want to give you show you a photo of some of our community advisory board members. After Bill Hobson passed away, they named the street where 1811 Eastlake is after him, so we took a picture in front of the sign. And sadly, because this population is so deeply affected and vulnerable in terms of health, already 3 members from this photo have passed on. But I truly believe that their spirit lives on in the work that we've co-created. So over the second phase of the study, we developed a multitude of programs aimed at reducing alcohol-related harm and improving quality of life. And obviously, I don't have time to get into all of those various programs, but broadly speaking, they fell into 3 categories: leadership opportunities, meaningful activities, and I heard this again yesterday from both Jeanette and another one of the speakers, that when people are reconnected to their whakapapa, or they're reconnected back to things that are meaningful to them, this is when they can start healing. And finally, the third category was recovery and healing, alternative recovery and healing pathways. So here's just some photos. This is from our poetry program. We developed a one-on-one. We partnered with an agency, a nonprofit agency that worked with incarcerated youth to develop poetry, and we brought that organization to the housing program and developed a 1-session brief intervention, and all found that after that 45-minute intervention where they worked to develop a poem together, their craving for alcohol went down, their positive affect increased, their negative affect decreased. So these are the types of programs. They started a community garden. They started a zine. So this is a forum for where people can share their words, their thoughts. We can send out communications about the research and make sure that everyone is involved and can be as involved as they want to be. Here's a mural that folks made. So we saw Dr. Evans showing these murals across Philadelphia. And this particular mural was a theme of peace, hope, and conflict resolution and resiliency. And it sits on the 4th floor of that building to remind folks of those pieces. I do have a poem that I want to share from one of our members. So let's just see if this is going to work. Let's see here. This is Lavella. She's on our community advisory board, and she's been very active in participating in some of the programming.
Okay. Now remember, this is Ellie's last time, right?
16.
No, 2 more times, but then I'm talking about the reading.
Oh,
This is my last reading that I'll be at.
This will be her last reading. My first one is called Blindfold. For the longest time, I've had a vision problem. I've had glasses. My glasses were taken here at 1811, which is how I came to the situation I'm in. There was this guy, and he liked the shape of my glasses. And he took my glasses as his glasses, but he didn't look good in there. He looked like an ugly woman. I asked for my glasses back, and I asked how it is that you can see out of my eyesight. I need my glasses. Then the man got sick from his alcoholism, and he wound up in Harborview. And because he trusted me, I became his power of attorney, and he still wouldn't give my glasses back. Because I checked his property. My vision was off, but I couldn't get another pair of glasses because I couldn't afford them. This leads up to my vision problem. And when we started the art project, I did the design of my art on my bathroom door where I could see. And then I could stand on a little chair there and get up close so I could do the design. Now it's up on the wall on the 4th floor. And I did that partially blind. Not being able to see is like somebody not only blindfolding me, but handcuffing me, but not binding my mind. Wow.
Okay, now we're going to see if I can get back to the presentation. Oh. Okay, great. So our aim for the LEAP was to evaluate whether this multidimensional package actually worked to reduce alcohol-related problems and increase quality of life. And so we tested the LEAP in what we call a 2-arm, 6-month non-randomized controlled trial. I'm just going to kind of go through these quickly so that we can get to the final piece here. So here's what people had to say about the LEAP. Overall, it's a very good distraction from drinking. I think that there's a lot more residents that would cut down on their drinking if they actually participated. It's been life-changing. It has changed the ecology of the community. For the University of Washington and the programs that you are bringing in is saving people's lives. It's bringing people back from the dead, and I'm not talking about physical death. Somebody that's already spiritually dead. We're trying to give them CPR, and we're doing it through art, we're doing it through talking, and we're doing it through writing. So, did the LEAP actually work? Well, 1811 residents who had access to the LEAP had significantly higher scores on a measure of meaningful activity participation compared to control participants who received services as usual. We also observed a medium effect size for reductions in peak alcohol use. When we look between when we looked at pre and post within subject changes in LEAP participants from their baseline to 6 months post introduction of the LEAP, we see significant within subject decreases in peak alcohol quantity and alcohol-related harm among LEAP participants. And this effect was dose-dependent, so that every LEAP-sponsored activity that a person participated in, their typical and peak alcohol use and alcohol-related harm decreased by 2%. So we tested LEAP as a multi-dimensional package, but I just want to let you know that it also served as a platform to launch and evaluate other harm reduction-oriented treatments. And for those of you who are coming to the training tomorrow, I'll be talking a little bit more about those specific treatments. But we've had the opportunity to test those in the larger community through randomized controlled trials, and we're finding that people's alcohol-related harm is reducing, their peak alcohol consumption is reducing, and even though our interventions do not ask people to change their drinking in any way that they do not want, we're still seeing a reduction in positive urine tests. So the LEAP and interventions designed using this kind of participatory framework indicates promise in helping individuals with lived experience of homelessness and alcohol use problems. And when we bring everyone to the table and make addiction everybody's business, especially those that are affected by the problem, we're coming up with these effective, acceptable, feasible, and culturally relevant ways forward. And I think this is where we need to be directing our efforts. Science is telling us that these harm reduction approaches are working. But finally, I want to come back to the war on drugs and talk to you about one more evaluation that my colleague and I have conducted showing promise of harm reduction approaches. And this relates back to what the Honorable Judge was talking about in the previous presentation. So in an attempt to move away from the war on drugs model and to reduce gross racial disparities in police enforcement, the Law Enforcement Assisted Diversion Program was developed and launched in Seattle in 2001. So LEAD is a police-driven, pre-booking diversion program that diverts low-level drug offenders and sex workers who come into contact with the criminal justice system out of incarceration and into harm reduction-oriented case management services. And LEAD was a result of unprecedented collaboration between police, prosecutors, civil rights advocates, public defenders, political leaders, and a multitude of other individuals who were really working together to find new ways to solve problems for individuals who were frequently cycling through the system. In fact, when we talk about LEAD, we often do so with our various partners, and you will hear the police officers saying, you know, I would go down and I would arrest Joe on 3rd and Union, and then we'd book Joe and we'd put him in jail, and then 2 days later, Joe would be back on that same corner doing exactly what he was doing before, and we realized that something was not working. And in fact, we were clogging up the system with these low-level drug offenses, you know, that didn't leave room for other more serious crimes. So our team, Susan and I, were invited to conduct the evaluation of this program, and were able to procure independent funds to do so. And so I just want to briefly talk to you. I know that time is getting low, but I briefly just talk to you about the 3 aims that we looked at, which were looking at LEAD's impact on criminal recidivism, LEAD's impact on cost and systems utilization, and then LEAD's associations with housing, employment, income benefits. And one thing, again, I want to point out is that we, from our sample, 60% of our participants were African American, despite only making up 8% of the general Seattle population. So we see lead participants were 58% less likely than people in the control group to be rearrested, I should say. Lead participants were 39% less likely to have a subsequent felony charge than control participants. Lead participants were booked into jail 1.4 fewer times. They spent 39 fewer days in jail compared to control participants. They had an 87% lower odds of at least one prison incarceration, and they cost the system $3,861 less per person than the system as usual participants. Lead participants were 40% more likely to procure housing or shelter during their follow-up period, and every contact that they had with a lead case manager meant a 2% higher likelihood of being sheltered and a 5% higher likelihood of procuring permanent housing. They were 33% more likely to receive income benefits, 46% more likely to be on the employment continuum in vocational training or employed in the legitimate market. And more than that, housing and employment obtained during a person's involvement in LEAD was also associated with significantly less recidivism as measured by arrests. So for every month that they were housed, participants were 17% less likely to be arrested. And for every additional month that they spent on that employment continuum where they were doing something and they were busy, they were 41% less likely to be arrested. So housing and employment appear to serve as protective factors against subsequent arrests. So finally, in my research for this talk, I was very heartened to learn that New Zealand and the national drug policy has a harm reduction bent at its core. Also, I know that a lot of the things that I've been talking about are featured in the current political climate. So from national talking about implementing Housing First on the one hand, which is a program that has been shown to work, and then on the completely opposite side of the spectrum, taking a tougher on crime approach to people who use and sell drugs, which has not been shown to work. From the Green Party talking about decriminalizing drugs and focusing on substance use as a public health issue rather than a criminal justice issue, to Labor talking about protecting tenant rights. New Zealand is a country with less bureaucracy, I should say, and very progressive in its policies. And I know because when I lived here, I worked for New Zealand Police as a researcher. And I remember I could go directly to the police commissioner and say, X, Y, and Z, and this is what I've found. And in the United States, the layers are a little more nuanced than that. So I believe that New Zealand has an opportunity to be world leaders in their policies around substance use. And if I can offer any advice based on the US experience, please don't become another failed statistic. Trust me, it is not fun to be on the wrong side of history, and it plays out in ways that we are now only starting to see in the current US landscape. All of the approaches that I've shared with you today have taken a collaborative approach that is centered around harm reduction principles. They've brought together people from all components of the issue, including those most affected by the problem, to help fix it. And it's only when we make addiction everybody's business and humanize substance users that we can come up with these kind of solutions and meet people where they are. Imagine what would happen if we put all the funds that we directed toward the criminal justice system into treatment and prevention efforts. And this is precisely what Portugal did in 2001, and by all accounts, it's been successful. We should continue to push for drug policy reform that decriminalizes nonviolent crimes while simultaneously playing a role in prevention, intervention, and rehabilitation, a public health approach as opposed to a criminal justice approach, an approach that works to humanize people rather than dehumanize them, as the war on drugs has done. Whatever way you vote in this election, one, please do, because your voice really does matter, and two, consider policies that are based on sound scientific evidence. Look at what has worked elsewhere and what has failed elsewhere. Consider policies that work to reduce disparities and lift up those who have been marginalized, because in doing so, you will lift up everyone and raise the quality of life for New Zealanders. I want to end my talk by quoting Dr. Vivek Murthy, who is our former 19th U.S. Surgeon General of the United States, and he stepped down in April under the current administration. He said, number one, kindness is more than a virtue. It is a source of strength. If we teach our children to be kind and remind each other of the same, we can live from a place of strength, not fear. Two, we will only be successful in addressing addiction and other illness when we recognize the humanity in all of us. People are more than their disease. All of us are more than our worst mistakes. We must ensure our nation always reflects a fundamental value, that every life matters. Three, healing happens when we are able to truly talk and connect with each other. That means listening and understanding. It means assuming the good, not the worst. And finally, four, the world is locked in struggle between love and fear. Choose love. Always. It's the world's oldest medicine. It's what we need to build a nation that is safe and strong for us and our children. So I want to end by adding to what Johann Hari said about connection being the opposite of addiction. The antidote to addiction, in my opinion, is unconditional love and connection. Thank you. Aroha nui.